For most parents, the pediatric well-child visit is the primary source of information on their child's health and development in the first few years of life. As the incidence of autism spectrum disorders continues to rise, pediatricians are facing increased pressure to keep pace with expectations for earlier diagnosis and intervention. And while the age of diagnosis has slowly been decreasing, we know that it continues to be later for minority and economically disadvantaged children. We also know that our general developmental screening tools may miss many children who go on to receive a diagnosis of ASD. In keeping with this, the American Academy of Pediatrics and the CDC have recommended autism-specific screening at the ages of 18 and 24 to 36 months. But despite these recommendations, not all pediatricians are regularly screening all children for ASD. Therefore, we propose that implementing more stringent requirements for autism-specific screening at 18 and 24 to 36 months, as well as requiring training in primary care providers in screening practices, will result in earlier diagnosis and intervention. Next slide. There is a wealth of evidence supporting this policy. First of all, it is well established that early intervention leads to better outcomes for children with ASD. We know that ASD can be reliably diagnosed at or before the age of 2, and that we can begin the formal diagnostic process as early as 12 months. This is especially important for families who have a child with ASD, as it allows them to make more informed decisions regarding family planning, since they do face an increased risk of having a second child with ASD. We also know that population-wide screening not only results in earlier diagnosis and intervention, but it also shortens the gap in age of diagnosis between children with a higher socioeconomic status and those who are economically disadvantaged. Finally, in Connecticut, we have successfully implemented an academic detailing method of training that is composed of 4 components. We teach the early signs of ASD, we give them a screening instrument that they can use right away, we give them billing codes so that they can bill for autism-specific screening during the child's well visits, and we give them information on how to refer for diagnostic evaluations and therapeutic services. And this method has been found to increase screening rates. Next slide. We know that despite our best efforts, that some practices have found it difficult to implement screening recommendations. We need additional research to determine why this is, so that we can modify our training programs to accommodate their needs. We also know that this policy will create a substantial need for additional diagnostic and therapeutic services. We also need research to determine where these services currently exist and where we need to work to establish them. We finally need research to ensure that our diagnostic and screening methods are in keeping pace with our current diagnostic criteria. And lastly, we know that additional research is needed on recurrence risk so that we can develop more effective screening timetables for younger siblings of children with ASD, as well as ensure that our current timetables are appropriate as more research comes in on early symptoms. Next slide. Implementing a screening program on its own isn't very difficult because we already have several brief and reliable screening instruments that are available for use. In Connecticut, we use the MChat, which is available at no cost to pediatric practices. It's downloadable and translated into more than 30 languages so that it can be used with culturally and linguistically diverse populations. We also have designed a training program that is 30 to 45 minutes in length and can be easily adaptable to online or other training formats. We know that billing helps to offset the costs of screening. We do recognize, however, that in locations where the diagnostic and therapeutic infrastructure is not in place, this policy will be more difficult to implement because we don't want children who screen positive to sit on long waiting lists waiting for an evaluation. In conclusion, however, we do feel that we have a critical opportunity to improve the lives of children with ASD and their families through ensuring that primary care providers are trained in early diagnosis, and screening. Thank you.